in UPM in 2007, followed by her master's in ophthalmology in 2015. Subsequently, she continued her training in medical retina in Hospital Shah Alam, Hospital Selayang, as well as the Queen's University of Belfast under Prof. Naomi Lewis. Here is her talk on perioperative management of uveitic cataract. Over to you, Dr. Amelia.
Thank you, Daphne. Good afternoon, everyone. Actually, I would like to thank the Young Ophthalmologist Group for giving me the opportunity to speak in this webinar. So today, I'm going to talk about perioperative management of uveitic cataract. So as you know that uveitic cataract is actually very commonly seen in those uveitic eye. This is mainly due to presence of chronic inflammation and long-term steroid usage. Even though today we have more potent anti-inflammatory drugs and new advances in the surgical technique, which has improved the surgical outcome of the cataract surgery. However, these patients are still at risk of intraoperative complication and also persistent inflammation postoperatively, whereby they will end up with macular edema, and this will lead to a poor visual outcome. Up to date, there's still no standardized guideline or consensus regarding the prophylaxis and the medical treatment during the perioperative management of uveitic cataract surgery. So what are the challenges in uveitic cataract? Most of the patients that you see in the clinic, they actually have a small pupil. This is mainly restricted by the posterior synechiae, periphery anterior synechiae, cyclitic membrane. And most of them usually have dense cataract or dense BSCC, which obscure the fundus view. And those in the viral cause of anterior uveitis, they tend to have the iris atrophy. This may lead to floppy iris intraoperatively. Other than that, you may also encounter patients with shallow AC and with concurrent corneal pathology, such as band keratopathy and corneal scar. So is it worthwhile to do cataract surgery in this patient? Actually, there's a randomized control trial, which is the multi-center uveitis steroid treatment trial. It actually showed that there's a substantial visual gain after cataract removal. So in this trial, actually, they compare the efficacy of intravitreal fluocinolone steroid implant versus corticosteroid systemic usage. And in this implant group, actually, they found that most of the patients developed cataract in the follow-up period of the 2 years trial. And this patient underwent cataract surgery, and they look at the outcome. They actually found that 23 letters gain in all these patients at post-op 3 months. And this visual gain actually maintained throughout the month 6 and also month 9, which is shown by the graph in the right side. And bear in mind that this patient is actually treated by uveitis specialists. They are actually well prepared for surgery covered with steroid, either local treatment or systemic steroids. And they will actually intensively treat to control the post-op inflammation. And it shows that, it just tells us that from this study, patients with uveitic cataract, actually they can gain vision if you remove the cataracts. And in postoperatively, what are the types of patients that is actually most suitable to list for cataract surgery? Patient selection is actually very important. For those cataract that obscure the fundus view, you can list them for cataract surgery, or those cataract that have significant visual drop. You may not want to list those patients that have mild cataract, or those patients with good vision. For example, patients with posterior segment involvement with dense macular scar, probably secondary to oculotoxoplasmosis. You know that this kind of eye poor vision is secondary to the macular scar, not due to the mild cataract. So you would not want to list this kind of eye for cataract surgery. So besides that, I would like to actually reinforce on the importance of pre-op assessment and also counseling on this patient. This is actually very important for junior doctors who are sitting in the pre-op clinics. They have to make sure that this uvatic eye is actually quiet, and I would like to further elaborate on the different types of uvatic cataract with different visual outcome. So in the pre-op assessment clinic, doctors should actually look actively for presence of macular edema, because macular edema may actually worsen post-operatively, and this may be recalcitrant to treatment after that. And to look for poor prognostic signs such as presence of optic neuropathy, macular scar, or macular atrophy. And the doctors need to explain as well the risk of intraoperative complications such as additional maneuver needed, and complications such as PC-RAN, bleeding from the iris, and etc. And post-operatively, we have to actually prepare the patient that they need to be compliant to their eye drops, their medication, and also compliance to the follow-up, as we need to monitor this inflammation post-operatively closely, as they are actually at risk of developing CMO, which is actually contributing factors to poor visual outcome. Besides that, we need to actually treat the inflammation aggressively to prevent hypotony, because this is actually one of the signs that may predispose to phthisis bulbi. Besides that, we also need to explain to patient that post-op inflammation can also contribute to glaucoma, which may need secondary operations such as filtering surgery. So let's talk about the visual outcome of cataract surgery in different types of uveitis. For fish heterochromic uveitis, usually these patients fare quite good post-operatively. But the problem is that intraoperatively, they may at risk of having hyphema, and post-operatively, they may develop posterior capsular opacity as well as the vitreous opacity. And studies have shown that 35% of these patients actually may develop permanent intraocular pressure elevation following cataract surgery. And eventually, they may need glaucoma surgery. And how about ocular Behçet's disease? This is actually an inflammatory condition which usually involves the posterior segment. And most of the time, the visual outcome is actually poor compared to other types of uveitic condition. And besides that, Behçet's patients usually are at high risk of having relapse up to 36%. A study by Japanese group actually suggested that these eyes should be kept quiescent for 6 months at least before they were listed for cataract surgery. And why 6 months? In their study, actually they found that those patients that have frequent relapse 12 months before being listed for cataract surgery, they tend to have more frequent uveitic attack after the cataract op. As you can see here from the chart here, those patients that have a frequent attack 12 months before the cataract surgery, they tend to have more frequent attacks post-operatively, and this result is actually significant. Therefore, they actually advocate 6 months of eye quiescence before listing the Behçet's disease patient for cataract surgery. This is an example of ocular Behçet's disease. As you can see here, this clearly showed that they actually have posterior segment involvement. This is actually a burnt out retina. Patient has a very pale optic disc bilaterally with sclerosed vessels in all 4 quadrants, and the OCT showed bilateral fovea atrophy. If you're going to remove cataract in this kind of eyes, most likely you won't get a good visual gain. This is another case of autoimmune disease, SLE retinopathy. As can see here from the fundus photo, patient actually had ischemic involvement in the posterior pole, whereby there are presence of deep blood hemorrhages at the macula as well as multiple cotton wool spots. And if you do an angiogram on this patient, you could actually see extensive capillary fallout involving the macula, and there's actually increase in fovea avascular zone. And you won't expect that this patient may do good in the surgery. Usually their visual outcome are actually poor. You need to show the images to the patient and counsel properly beforehand. And in JIA cases, usually patient with JIA falls in the embryogenic group, and the surgeon actually have to balance up between the cataract removal versus the interval of quiescence eye. So rehabilitation in this kind of eye is usually more difficult compared to other kinds of uveitic cataract. And studies have shown that they actually have poor visual outcome in conventional cataract surgery without any IOL implant. And it is actually advisable to give a systemic, local, or topical corticosteroid perioperatively and have zero tolerance to the AC cells. And what's the problem that usually doctors face in seeing this JIA case post-operative is that they may develop a very severe post-op inflammation, fibrin in AC, and developing cyclitic membrane. And once if cyclitic membrane is formed, this may actually cause a detachment on the ciliary body, which may lead to hypotony and phthisis bulbi. So this is actually a sight-threatening event. So you might need to actually aggressively treat this patient post-operatively, and you may need to actually do the operation one by one instead of like do a subsequent consecutive operation in one eye, followed by another 2 weeks of cataract operation in 2 weeks' time. So besides that, they're also at risk of glaucoma, secondary pupillary block, and also capsular fibrosis or PCO. Other conditions such as ocular TB, serpiginous choroidopathy, if the lesion involves the macula, you won't expect them to have a good visual gain post-operatively. Another case of a high myopic lady with underlying punctate inner choroidopathy and advanced glaucoma. As you can see here, the patient actually has a very advanced cupping, 0.9 cup to nearly fully cup disc, and you may need to do a visual field assessment to look for macular split and counsel for white-out syndrome before you touch the eye. And in cases of VKH, usually these cases have good visual outcome, but then there are several vision limiting factors such as subretinal gliosis or optic atrophy or pigmentary changes on the macula. If all these changes is found in the fundus, you won't expect to have a good vision. But one good thing about VKH is that they tend not to have CMO in the post-operative phase. It is actually uncommon to see CMO in VKH. So this is another study done in China. They are actually doing a retrospective review of 80 eyes with different uveitic conditions such as HLA-B27, JIA, Behçet's, Fuchs heterochromic uveitis, rheumatoid arthritis, and VKH. And they actually found that Behçet's disease is actually had a poor visual outcome with higher logMAR value at the final visits shown by the graph here with the red color column here. Asterisk shows that this result is actually significant. So with different uveitic condition, you may need to counsel them differently, and the best is to show them images and also OCT changes so that they understand their eye more and don't have high expectation post-operatively. So when is the best timing to list them for cataract surgery? Quiescence eye for 3 months is actually recommended, but in Behçet's disease, you can actually watch them up to 6 months if in the previous 12 years if they have frequent uveitis attack. Except those cases with lens-related uveitis, you may need to actually have immediate intervention, especially in phacolytic glaucoma cases or phacoanaphylatic uveitis. You know that the problem is actually arise from the lens, so you need to remove the lens as early as possible. So for those dense cataract with intraocular inflammation, despite having heavy immunosuppressants, you can actually give them an IV methotrexate 1 gram on the day of operation. And why is it that we need to keep the eye inactive for 3 months before listing for cataract surgery? By definition, remission of uveitis is actually inactive uveitis for 3 months without any medication immunosuppressive agent. However, in this kind of cases, uveitic cataract, you cannot stop all the medication for 3 months before listing them for cataract surgery. They will have relapse. So what I meant by 3 months disease, inactive disease of uveitis is that you actually continue their current medication, their immunosuppressive agent or topical steroids, and you watch them for 3 months. If they are inactive, yes, you can list them for cataract surgery. So a study by Blair, a prospective study comparing a uveitic cataract eye with 52 normal eye to look for incidence and risk of cataract operation, risk factor of post-op CMO. They actually found that those eyes with active uveitis in less than 3 months, and if they are listed for cataract surgery, they are actually 6 times higher chance of developing a post-op CMO. So besides that, they also found that those patients with perioperative oral corticosteroid usage compared with those without corticosteroid usage, they are actually at 7 times reduction risk of developing CMO. If you prescribe a systemic corticosteroid to this patient preoperatively, they're actually 7 times less likely to get a CMO postoperatively. So this is actually the interval time that you need to wait for 3 months, and certain cases like Basher, you may need to wait for 6 months of eye quiescence. In other scenarios, such as like surgical induced necrotizing scleritis, there's a case of Marfan syndrome with history of RRD, and the patient had a right scleral buckling done, and he developed surgical induced necrotizing scleritis post-op 5 months after the surgery. And you know that actually Marfan syndrome is actually a defect in the extracellular glycoprotein, and the presence of foreign body which causes thinning on the sclera. You need to remove this scleral buckle as early as possible. So what you can do in this case is that you cover them with corticosteroid, and then you do not need to wait for 3 months, and you need to remove the scleral buckle as early as possible. So for prophylaxis, prophylaxis in non-infectious uveitis is actually different from infectious uveitis. I'll talk about the non-infectious uveitis first. In those cases with mild anterior uveitis, it is adequate to just give a topical steroid alone, QID dosing 1 to 2 weeks before op. And how about those intermediate uveitis, posterior uveitis, or pan uveitis? You can actually prescribe oral prednisolone, 0.5 milligram per kg for 14 days, or 1 milligram per kg 3 to 5 days before operation. And you may also give local therapy, periocular steroid triamcinolone, or intravitral Ozurdex. NSAIDs is also useful to give 1 week beforehand to prevent post-op CMO. So for those patients with underlying inflammatory or autoimmune diseases, it is actually advisable to speak to the physician to make sure that their systemic autoimmune is actually not in active stage before you list them for cataract surgery, and then to continue the second-line immunosuppressant as well. So which steroid regime is actually useful? There's a prospective randomized trial comparing 2 different regimes, either giving IV methotrexate 50 milligram per kg 30 minutes before surgery, which is about 1 gram dose before cataract surgery, comparing with 2 weeks of oral prednisolone 0.5 milligram per kg. So when they look at the efficacy of these 2 regimes, they actually found that the the post-op blood aqueous barrier recovery is better in those with oral prednisolone 0.5 milligram per kg group. As you can see from the bar chart here, the patients who were receiving IV methylpred actually has higher flare than the patients on oral systemic corticosteroid at 7 days, 28 days, and 3 months. So in my practice, I usually will give prednisolone 0.5 milligram per kg 2 weeks before I list my patients for cataract surgery in those non-infectious uveitis cases. How about infectious uveitis? So for infectious uveitis, there are conditions such as acute retinal necrosis secondary to VZV, HSV. These kind of conditions tend to recur after cataract surgery. You may need to prescribe oral acyclovir 400 milligram BD or vial acyclovir 1 week before op, and you may continue them 2 weeks post-operatively. And topical steroid is actually useful as well because it is less risk of leading to hepatic corneal lesion than steroid. And if you're going to give a topical steroid alone, you have to be aware that there's a risk of reactivation of hepatic lesion in the cornea post-operatively. You have to watch them closely. And then for oculotoxoplasmosis, it is actually common to see that reactivation of toxoplasmosis post-cataract op. It is up to 36%. And it is actually controversial whether it is necessary to give preparation of oral antiparasitic before the operation or post-operatively. It's actually up to surgeon's preference. If you're going to prescribe prophylaxis treatment, you can actually give oral azithromycin or oral Bactrim 1 tab per day, 1 week before op, and you can continue up to 2 to 3 weeks post-operatively. Some surgeons actually give intravitral clindamycin 1 milligram per 0.1 ml intraoperatively. So this is an example of ocular toxoplasmosis. If you have a case of ocular toxoplasmosis which has the lesions which locate near to the fovea, this is a case that the patient have a first ocular toxoplasmosis which is just as adjacent to the fovea. The vision is still good at 6-9 after healing, after treatment. However, patient may have another reactivation adjacent to the scar, and this may cause drop of vision to 6/24 after treatment with more foveal atrophy, as shown here. So in this kind of scenario, you may consider to give antiparasitic medication before pre-op and also to continue up to 2 weeks post-operatively for a case of ocular toxoplasmosis. And if the lesion is actually far away from the macula in the periphery, I think prophylaxis may not be needed. So, but it's still up to the surgeon's preference. So in case of endogenous endophthalmitis, as long as the infection is treated, there's actually no indication to start prophylaxis for this patient. You do not need to prescribe antibiotic or any steroid for this kind of ocular condition. As long as the infection is treated and it is quiescent, then you can list them for cataract surgery. So you need to plan your surgery. In cases that patients that have band keratopathy, you may need to remove them before the cataract op because the band K may obscure your surgical view. And you can actually remove this by using 1 to 2% of sodium EDTA chelation. There's a case series published by using off-shell potassium EDTA for band K. Potassium EDTA can actually found in the FBC tube as labeled on the tube here, potassium EDTA, and each FBC tube actually contains 5.4 milligram of potassium EDTA. what you can do is that if you look carefully on the tube, there are actually multiple micro droplets lining on the tube, and this actually contains EDTA. What you need to do is that in those hospitals who do not have a compounding pharmacy to prepare disodium EDTA, they may actually use the EDTA from this FBC tube. You just need to inject a sterile water into the FBC tube and then swirl the FBC tube to dissolve all the micro droplets from the tube lining. You may need to repeat this process up to a total of 5 tubes. And the concentration of the volume of the liquid is actually 0.1% of EDTA. And you can actually proceed with your band K removal after that. I have a link here in the slide here. You may actually copy this and check it out in the website on how to remove, on how to get this EDTA from FBC and also band K removal. So this is another case of granulomatosis polyangiitis. Patient actually has superior peripheral ulcerative keratitis and also scleromalacia. So you may need to actually co-manage with the cornea team regarding the surgical approach of cataract removal, because you may need to avoid the PUK incision site. In this case, you may actually approach temporally because the PUK is superiorly. And actually, very sorry that I actually have one more photo to show the scleromalacia at the superior part of the sclera. I do not know why it didn't appear on this slide. So anyhow, you have to be aware that scleromalacia, actually there's a potential risk of globe rupture during the operation. So I think the best team to manage this case is the cornea team. They may be able to perform a scleral patch if globe rupture happens. So intraoperatively, you may need to consider on the position of the patient. If the patient have ankylosing spondylitis, you may need to position them in a Trendelenburg position. And you may need to give an adequate local anesthesia, peribaba block or subtenon block. As you know that this surgery is going to be a difficult one. You may need a longer period of surgery time. And you can actually make a clear corneal incision with long tunneling to prevent floppy iris, and try to avoid scleral incision in cases with scleritis. Try to open up the small pupil. Later on, I will elaborate more on small pupil management. And when you get an adequate pupil size, you may need to do a good size of capsulotomy between 5 to 6 mm. This is to prevent anterior capsular phimosis. And it is important to clear the cortical matter fully to prevent post-op inflammation. And IOL into the back, you can actually use the acrylic lens, either hydrophilic or hydrophobic. It is actually compatible to the uveal tissue. And make sure that the haptic is actually in the back. This is to prevent UGH syndrome or causing iris shuffling post-operatively. And try to avoid ACIOL if you encounter complication intra-op, because ACIOL tends to cause iritis post-operatively. So in the case of at the end of cataract surgery, you may need to give intracameral dexamethasone 0.5 milligram if you expect that post-op inflammation can be very severe. Or some surgeons prefer to give intravitreal Ozurdex or periocular triamcinolone 40 milligram at the end of the surgery. But you must remember that steroid implant is actually contraindicated in infectious uveitis such as toxoplasmosis or ARN, etc. So for management of small pupil, sorry, I'm very sorry that I don't know why the title of each slide has changed to a different one. Can I just stop for a while? Daphne? Daphne?
Sure, you want to reload your slides, Amelia?
Yeah, because the title of each slide is actually wrong.
Meanwhile, if anyone has any questions, feel free to type it in the Q&A box at the bottom, and our speakers will answer at the end of the talk. Yeah.
Sorry, I need to reshare my slide. Are you still seeing my slide? Very sorry about the...
Not right now.
It is supposed to be small pupil, but I don't know why it turned out to be GPA. Can you see my slide now, Daphne?
No, you try to share the screen again.
Okay, a while, yeah? Can you see my slide now?
No. Yeah.
Okay. I apologize for the technical issue.
Okay.
By the way, this is better, right?
Yes.
Okay. Okay. This is a picture of sclera Malaysia. As you can see that the sclera is actually very, very thin. You may need to manage together with the cornea team, preferably to let the cornea team to operate the cataract in case if there's a sclera rupture, they may be able to patch it. It may be difficult to patch as well. So intraoperatively, just go through my slides here, positioning, adequate local anesthesia, and try to avoid a PUK site of incision if you have a case of PUK, and avoid scleral incision in case of a scleritis. Have a well-sized capsulotomy, 5 to 6 mm, and try to complete the cortical removal, make it a clean one to prevent post-op severe inflammation. And make sure the IOL is inside the bag, and you can give intracameral DEXA 0.4, intravitreal Ozurdex, or periocular triamcinolone. And must always remember that steroids implant is actually contraindicated in infectious uveitis because they may reactivate post-operatively if you give the intra-op implant. Periocular is fine, but not intraocular. So for cases of small pupil management, usually intracameral adrenaline is not helpful. You may need to release the posterior synechiae before you can open up the pupil. But in case that if you have a periphery anterior synechiae, you need to release the PAS first before the PS. And then you perform a synechialysis and removal of pupillary membrane, followed by viscodilatation. If viscodilatation fails, you may need to use a 2 Coulomb hook to do a push and pull technique. And this is to stretch the pupil and to further expand the pupil size. And try to avoid this technique in cases that have atrophic pupil, because this may cause a permanent tear on the pupil, and patient may remain as a dilated a pupil at the end of the surgery and also post-operatively. And other devices for pupillary dilatations are iris hook, myogene ring. Iris hook is actually useful in cases with shallow AC. And for myogene ring, actually you can, it is also useful to use to open up the pupil, but it is not very helpful if you're going to use it in eye with iris atrophy or shallow AC. Just some video to show how to peel the membrane. So what you initially need to do is you inject visco. Then after that, you try to grasp the edge of the membrane and then try to pull it and make a circular shape and slowly pull it gently to prevent further iris bleed. Actually, there will be definitely some iris bleed when we are doing peeling of the membrane. But make sure you be gentle when you are doing the procedure. Okay. And then this is how you actually insert a myogene ring. After open up the pupil, you are able to make a good size CCC. This is actually very important. So every step is actually very important in uveitic cataract to avoid post-op complication. So another video on how to release the Synicate. So after you make the main incision, you can actually inject viscoelastic to maintain the anterior chamber depth. And then after that, proceed with synecholysis. Try to find a space in between the pupil and the lens. And then you start to inject viscoelastic and try to sweep underneath the pupil to separate the iris from the anterior lens capsule. This is how you do the synecholysis. So another way to release the posterior synicate from the anterior capsule, you can actually use a Coupland hook and try to drag it, pull it away from the anterior capsule like this. So after you have obtained a good size of pupil, then you can actually paint the anterior capsule with the Trifon blue. So you do not need to remove the viscoelastic in the AC. You can just directly inject the Vision blue just on top of the anterior capsule to paint it. And further viscoelastic to clear up the Vision blue. followed by capsulotomy. A good size of CCC is very important to prevent capsulophimosis. Okay. So special consideration during the operation, you may need to preserve the conjunctiva for future glaucoma procedure. Try to avoid incision of sclera, especially in scleritis eye. Avoid ACLL, which may lead to further iritis post-operatively. And also make sure that you stand by a CTR if, let's say, you suspect there's actually unstable capsular bag. And some surgeons actually prefer to suture the wound, even though it is watertight, because intensive topical steroid post-operatively may actually cause a slow wound healing. But this is actually surgeon's preference. So for post-op management, you need to monitor the patient closely, and you may need to give an intensive topical steroid like maybe hourly for the first 3 days or 2 hourly subsequently. And then monitor them 1 to 2 weekly, is depending on the severity of the post-op inflammation. And if the inflammation is very bad with fibrin, you may need to give intracameral RTPA. Then how to taper oral prednisolone. You may taper them slowly, every 5 milligram until 20 milligram daily dose. Subsequently, when you reach 20 milligram daily, you taper even slower, every 2.5 milligram weekly until the pre-flare-up dose. And during the period of post-op management, please continue the same dose of second line. Do not change any dose of second line off the second line, or reduce the dosage of the second line. Just make sure that you need to continue the second line. If the inflammation is very bad, you may need to dial up the dose of the second line as well. And topical NSAIDs is actually useful to prevent cystoid macular edema. Periocular triamcinolone or Ozurdex can be given if it is not responding to NSAID for case of CMO. So this is actually a study to show that NSAID is actually better in preventing CMO at post-op 1 month. They're using, this is a meta-analysis whereby they compare NSAID, topical NSAID with various kinds of topical steroid, betamethasone, dexamethasone, and fluorometharon. And you can see here from the risk ratio here, it's more favor to NSAID. So NSAID is actually proven effective in preventing CMO in post-operative period. So what are the risks of uveitis inflammation to the IOL? So you may see precipitates on the IOL, cocooning of the IOL. You may have extensive pupillary posterior synechiae leading to pupillary block and secondary glaucoma. Patient may develop cyclitic membrane or posterior capsular opacification. So for capsular phimosis, you may actually do a YAG laser on the anterior capsule like this, a radial nick on it to release the tension on that anterior capsule. So for post-op management, you need to have a frequent follow-up, a detailed fundus examination, and remember to do an OCT to look for CMO. And you must actually monitor the IOP as well, because they are at risk of glaucoma, and aggressive control of inflammation. So for take-home message, please select the correct patient for surgery. you must actually assess them properly, preoperatively, and have an adequate, good counseling for this patient, and not to, especially patient's expectation. Most of the patients may think that they have cataract and they expect after cataract removal, they have a good vision. So you must really show the photos, images to the patient, explain to them by removing the cataract, even though it's indicated, but they may not get a good vision because of the pathology in the eye. So you may need to co-manage, plan your surgery, because you may need to co-manage with other teams like cornea, glaucoma, or BRT. Close monitoring of this patient post-operatively and treat the post-op inflammation aggressively. So lastly, I would like to thank Dr. Chung Yi-Fong for contributing his cataract videos, and also to thank my junior doctor, Dr. Tam, for video editing. That's all. Thank you.
Thank you for that very informative talk, Dr. Emilia. It will certainly be very helpful when we are planning for cataract surgery in patients with uveitis. If you have any questions, feel free to ask in the Q&A box below, okay? So we will now proceed to the second talk of the day by Dr. Sangeeta Kuganesan. She's a Medical Retina and Uveitis Fellow from Hospital Selayang. Dr. Sangeeta completed her medical degree at IMU in 2005, followed by her master's in ophthalmology in 2014 in UM. She's currently a third-year fellow and will be completing her fellowship early next year. Her talk today will be on injection-related endophthalmitis. Over to you, Dr. Sangeeta.
Thank you, Daphne. Can you hear me loud and clear?
Yep.
Okay. Hi, everyone. Nice of you all to stick around on a Saturday afternoon when you could be doing so many interesting things. And thanks to Malaysian Young Ophthalmologists and MSO for the opportunity to speak again. Okay, so my topic is actually something very common, and most of you are well aware of this. I'll just provide some updates regarding injection-related endophthalmitis. Okay, so currently it's said that intravitreal injections are actually now the commonest performed ophthalmic procedure, and this is due to the advent and rise in the studies of anti-VEGF. As we all know that there's a medical breakthrough currently going on with treatment of diabetic macular edema, AMD, and retinal vaso-occlusive diseases. And the usage of anti-VEGF is on the rise. Okay, so what exactly is intravitreal injection-related endophthalmitis? It's also termed post-injection endophthalmitis. It's basically a specific endophthalmitis that develops following intravitreal injection of drugs. So there are actually many complications that are related to intravitreal injections, like as we all know, temporary rise in IOP, lens touch, there can be intraocular bleeding, retina detachment, and so on. But the most feared complication is actually endophthalmitis, as it is associated with poor visual prognosis, even with the most prompt diagnosis and treatment, and visual loss is common. So classification, just like post-op, post-cataract surgery endophthalmitis, it can be divided into fulminant, acute, and chronic. Its average presentation can be from 24 hours to 26 days with an, the range of presentation is 24 hours to 26 days with an average presentation at 4 days. So patients as in post-cataract endophthalmitis, this is nothing new to us. They usually present with swollen eyelids, injected eye, purulent discharge. Their cornea may be slightly hazy due to inflammation or raise in the intraocular pressure. There will be hypopyon. There'll be fibrin in the AC due to inflammation, and they always have posterior segment involvement. So when there's no view, we would do a B-scan ultrasound, and we would see either dense vitritis or loculations depending on how severe the condition is. So what is the incidence of post-injection endophthalmitis? It is actually very rare. And studies done as early as 2008 until 2015 internationally shows that the range is roughly about 0.016 to 0.028. On this side of the slide, it's actually a study in US, and it's a retrospective review of 20 large case series. The average incidence is 0.28%, which is roughly about 1 in 3,544 injections. And this is a meta-analysis in France. the range is about the same. Even as early as 2008, the range of incidence is about the same. So what are the causative agents? Again, pretty much the same as post-op cataract surgeries. And the commonest is still Staphylococcus epidermidis, which is a normal skin flora. And the second would be Streptococci viridans. And of course, other organisms have also been isolated in previous studies. In current day practice, due to the rise in usage of intravitreal anti-VEGF, the rate of complications are expected to increase. So how do we manage this and how do we prevent this? There's a lot of variation and lack of consensus in current clinical practice guideline all over the world. However, the take-home message from this would be actually to practice safe medicine and use the clinical practice guidelines that is feasible for our own setting. So I will highlight some issues regarding prevention of endophthalmitis in intravitreal procedures. I will touch about topical irrigation and antisepsis, setting of the procedure, preventing respiratory droplets, hand hygiene, topical antibiotics, performing bilateral intravitreal injections on the same day, what is our recommendation, and what is the treatment. So topical irrigations, the commonly used topical irrigation in ophthalmology are Povidone Iodine 5% and Achos Chlorhexidine. Why do we need this topical antisepsis? It's because we all know that endophthalmitis is actually due to inoculation or ingress of microorganisms into the globe during injection. So we need to sterilize the ocular surface in order to perform this procedure. There have been reports when you omit antiseptic, there's a significantly higher rate in endophthalmitis. Even in the DRCR net, there was a 15% increase in developing endophthalmitis in cases that were performed without topical antisepsis. So what is so special about Povidone iodine? For ophthalmic use, we actually use a half-strength diluted Povidone. It's actually a broad spectrum antimicrobial agent, and it's very potent against not only bacteria, but fungus, virus, amoebas, and even spores. They have very low incidence of microorganism resistance, and Povidone is actually very cost-effective and widely available, very suitable for clinical setting. So Povidone iodine, when diluted, it has been shown in journals as far back as 1982, where diluted Povidone is found to be as effective as full-strength Povidone in reducing bacterial load on anywhere, not just the ocular surface. And in a lower concentration, it's definitely less irritating to mucosal surface. So it's ideal for the eye. When you dilute Povidone, you actually release free iodine, which are antiseptic in nature. So current evidence advises for a technique of a 10 ml flush of 5% Povidone iodine through the conjunctival fornix, and they've been proven to be more effective than just placing 2 or 3 drops of Povidone in the eye. And the exposure time that is clinically proven by studies is 30 seconds as compared seconds, as proved in one of a randomized clinical study before, where they compared different timing of exposure, and they found that 30 seconds was ideal to reduce bacterial load as compared to 15 seconds. So what is the issue with Povidone? As we all know, repeated exposure to Povidone, especially on mucous membrane ocular surface, it may lead to ocular sensitivity and dry eye symptoms, and this may bother patients to variable extents. So some people actually flush the eye with BSS or saline after the procedure to prevent this incident. However, that is not clinically proven, not even proven in any studies previously. So we can always treat the dry eye post-injection with topical artificial tears. Okay, so the next is Achos Chlorhexidine. It is a good alternative to Povidone in patients who are very sensitive to local irritation and allergy. And there's actually been a paper that showed that there's significantly lower patient discomfort in using chlorhexidine compared to Povidone. However, also it is as effective in reducing the rates of endophthalmitis. The rate of endophthalmitis in retrospective case series showed that there was very low incidence of post-op endophthalmitis. It's comparable with the usage of Povidone. However, the chlorhexidine has got multiple reports of resistance against MRSA strains and fungus. which is not present in povidone iodine. And it's also got a narrower antimicrobial spectrum. So that's the problem with chlorhexidine. So what about setting of procedure? As we all know, we have the option of performing intravitreal injections in an office setting or in an operating theater. Historically, anti-VEGF treatments were given in operating rooms because it was actually a modified posterior chamber paracentesis in vitreoretinal surgeries. However, of late, there have been many data of intravitreal injections performed in the UK and Canada, where these procedures were performed in dedicated clean rooms and in office setting with no major problems. And a lot of papers have proven that it's safe to give intravitreal therapy in both office as well as operating room setting. One such paper is by Tabender in 2014, where he did a consecutive case series for 3 years. And when compared, there was no significant difference in the rate of endophthalmitis in both office and operating rooms. Freeberg and Bande in 2017, they also produced some papers that showed, treatments papers showed that low incidence of endophthalmitis were achieved in operating theaters as what we would expect. And Bande et al. Showed that there was absolutely no difference, no additional safety benefits in performing in either outpatient clinic, surgery, or in other locations. So it is safe to perform in either settings. However, we must always bear in mind it has to be a dedicated clean room with sterile equipment. That's of course more important than the location. So next, respiratory droplet reduction. There was a study in 2011, a paper by McCannell, which showed that one of the common agents in yielded in the endophthalmitis cases was streptococcus, which is 31%, which is a lot higher than in post-cataract endophthalmitis. So this stirred other publications where because streptococcus is a normal flora in the oral cavity and the respiratory tract, a few studies were done where patients were advocated strict no talking policy, and they actually found that there's a decrease in post-injection endophthalmitis. And a paper by Garrick et al. Showed that there was significant reduction from 0.015 to 0.002 with a no talking policy in OT. And so that stirred other publications that showed when you use face masks, the aerosolization of oropharyngeal droplets reduced and also reduced endophthalmitis. And the proposed mechanism, as I said, is because streptococcus is from the oral flora, and the postulation is the treating physician and patient themselves, when they talk, there's dispersion of this oral flora. So hence, we would advise all staff members, patients, whoever's present in the injection room to always wear a mask to minimize talking. Okay, next is hand hygiene and antisepsis. How do you wash your hand before you perform intravitreal injections? Basically, skin antisepsis is broadly divided into aqueous scrubs and alcohol rubs. Our aqueous scrubs are povidone and chlorhexidine. So there is actually no study linking hand antisepsis and endophthalmitis. However, it is there's a paper that said that chlorhexidine and alcohol rub provide better skin antisepsis compared to povidone. This is on the skin, not the eye. So WHO actually worldwidely recommends that hand scrub with 4% chlorhexidine gluconate. This bottle here is probably quite familiar to all of you. So this is actually recommended by AO. So a hand scrub of 5 to 7 minutes would be adequate. So what about prophylactic topical antibiotics? This issue is actually still, I would say, unsettled. There's many controversies about this topic. So basically, topical antibiotics prophylactically can be classified as pre-injection and post-injection antibiotics. A study done by the American Society of Retinal Surgeons in US survey showed that 78% of US respondents do not use any pre or post-injection antibiotics. And this is because there are no prospective studies showing any benefit from both pre and post prophylactic antibiotic for injection. So one such study was performed in 2009, where the rate of bacterial cultures was actually slightly higher in those given pre-injection antibiotics compared to post. And the same with post-injection antibiotic, there is no evidence showing that it's beneficial in reducing the risk of endophthalmitis. There is one study by Story et al. In 2014, where a retrospective case control for a large population was done, and they found that prophylactic post-injection antibiotics was not associated with any change in endophthalmitis rate. And subsequently, there were two meta-analyses that concluded there might be an increase in the risk of endophthalmitis. So all this variable data has caused some confusion with the prophylactic antibiotics. However, the challenges that are, in theory, the challenges with prophylactic antibiotics is that it increases antibiotic resistance. And one paper actually proved this and said that it can occur as early as 4 days after initiating treatment. The frequent injection of anti-VEGF, the frequent use of antibiotics will cause antibiotic resistance. And also the repeated use of broad spectrum antibiotics can cause ocular surface dryness, and it's detrimental to the patient's eye. So, okay, the next is bilateral intravitreal injection on the same day. Many studies have shown that bilateral same-day injections are clinically safe, but we have to bear in mind that there are many factors that are associated with the increased risk in endophthalmitis in performing same-day injections, which are environmental factors, patient care, and iatrogenic infections. There have also been some isolated reports of bilateral endophthalmitis following same-day injections, but these were not studied in large trials. So it's important to remember that even though there is no harm in performing bilateral same-day injections, we have to bear in mind that each eye should be considered as a separate eye. Procedure should be sterile and separate without reusing instruments or medication for both eyes. And this would help to avoid the increasing risk of bilateral endophthalmitis. So what are the recommendations? These are pretty standard for all ocular surgeries. We have to rule out any predisposing lid abnormalities that will affect the ocular surface. Any infections, ocular, periocular, and systemic, should be treated, and injection to be deferred until the infection is completely treated. We would advocate a clean, sterile room, and preferably a dedicated room for injections and not shared with other procedures. Face mask is highly recommended to prevent droplets, and it's recommended that staff in the room to avoid or reduce talking. Sterile equipment is a must, and hand hygiene is advised. Eyelid speculum is a very important step in the injection, because the prevention of contact of the eyelash and lid margin with the sterile needle is very important in avoiding endophthalmitis. Next, Povidone Iodine, 5% Povidone Iodine placed in the eye for 30 seconds, and alternatively Achos Chlorhexidine. And AAO actually recommends reapplication of Povidone with a cotton tip at the site of injection prior to injection. So this is roughly how the injection tray would look like. It's a sterile tray with antiseptic agents, tuberculin syringe, a sterile lid speculum, sterile gloves, and preferably a sterile drape. So in my setting, this is how we do it. First we prepare everything in a aseptic technique, and then the patient is made to lie down on the bed, and topical anesthesia is applied. So the skin periocular tissue is cleaned with Povidone Iodine, and in my setting, we use a Tegaderm to very cleanly separate the lids and place it away from the injection site. And a speculum is placed. The conjunctival fornix is flushed with Povidone Iodine. So injection technique would be to measure from the limbus, the area of injection, to ask the patient to look away from the needle, and to inject into the mid-vitreous cavity. So post-injection, it is advised to use a sterile cotton tip to tamponade the area of injection to prevent vitreous reflux and vitreous wick. So what do we do after injection? It is very important to advise the patient and counsel to come back immediately if there are any slightest sign of endophthalmitis, and post-injection endophthalmitis should be treated as an emergency. And it's advised that all clinics performing intravitreal therapy should have access to an endophthalmitis kit and service to perform vitreous tap and injection of antibiotic intravitreous. So the algorithm of management is pretty much the same as post-op endophthalmitis, where a comprehensive history, a full examination of the anterior and posterior chamber is done, and then proceeded with investigations where we take a vitreous tab and we try to inject the intravitreal antibiotics within 1 hour, as well as send the samples for gram stain, culture, and sensitivity. And our intravitreal antibiotics would be vancomycin and ceftazidime to be given within 1 hour, and immediately after procedure to start intensive topical antibiotics and topical steroids, which will be given around the clock. We have to also make sure we give systemic antibiotics. And once we have reviewed the antibiotic microbiological results, we have to review our antibiotic regimen and treat accordingly. And as standard practice, we will repeat the intravitreal antibiotics after 48 to 72 hours. And bearing in mind that at the nearest possible time, early referral to vitreoretinal surgeons is mandatory, as urgent vitrectomy may be considered in some patients. Okay, that's all for today.
Thanks, Dr. Sangeeta. Hopefully, we can all avoid this dreaded complication with the information you have shared. We are going to share the QR code for this meeting first before it expires. So everyone get ready. Okay. Maybe just another 1 minute in case it takes some time to load the MMA app, yeah? All right, okay, so we'll be moving on to a short polling session before we move on to answering the questions in the Q&A box, yeah? Polling session. Okay. Just give a few minutes to answer the questions. Oh. Okay, so most of you have already answered. Okay, as for the first question, which preoperative parameter is the most important predictor of the outcome of uveitic cataract surgery? Majority answered AC cells preoperatively, which is the correct answer.
Yeah, I'm very happy to see that.
Question 2, when is the optimal time to operate a uveitic cataract? Actually, the answer should be immediately for phaco anaphylactic cataract, which about 36% of you answered.
So
I think the 3 months for question I for all types, I think probably not all types of uveitic cataract, right, Dr. Amelia?
yes, correct. Certain uveitic cataract, like I mentioned before, Behçet's disease, you may need to observe them up to 6 months of quiescence, okay? And then I think anyone answer 6 months of quiescence for all types of cataract? No. Earlier at 3 months if they are quiescence for certain normal cataract.
Okay, the third question, what is the risk factor for phthisis bulbi in post-op uveitic cataract? Majority answered hypotony, which is the correct answer.
Good, good.
All right, so we will move on with the next poll regarding Dr. Sangeeta's topic.
This one should be very fast, right? Got prize for winners, Daphne.
Special session with our speakers. Okay, we'll be ending our poll. Okay, so for the first question, evidence shows pre and post topical antibiotics help to reduce end-off rates, which is false. Yes, you answered correctly. The studies doesn't show that it actually helps.
Yeah.
For the second question, what is the commonest organism that causes intravitreal related endophthalmitis? The correct answer, coagulase negative staph, 80%.
People are listening. People are actually listening.
Yes. And for the third question, very tricky. Which statement is not true regarding pre-injection Povidone application? And the correct answer is actually B, which most of you got correct. After application onto the ocular surface, Povidone iodine should be left for an exposure time of 15 seconds. So actually it should be for 30 seconds, okay?
Yep.
All right, that was a very good polling session. Now we shall move on to the Q&As and see whether we have any questions from our participants. So the first question by an anonymous attendee, they ask, hi, Dr. Amelia, for non-infectious uveitis, we give oral prep for 2 weeks pre-op. What about post-op? Do we taper the oral prep? So Dr. Amelia already answered the question in our Q&A box. She said, yes, we do need to taper down the oral steroids slowly, but you may taper 5 mg per week until you reach 20 mg OD. then followed by 2.5 milligram per week until the pre-flare-up dose. Second question by Dr. Chow. Hi, Dr. Amelia. Thanks for your talk. What is your recommendation for treatment of CMV anterior uveitis and its perioperative regimen for cataract surgery? So actually, this is optional based on surgeon's preference, but she suggests that you may give topical ganciclovir 2% pre and post-operatively. And one important thing is to have to be aware of CMV reactivation post-operatively, especially when you use intensive topical steroid post-op. So most of us do not give topical Ganci pre and post-operatively as long as the infection is treated. You may list them for cataract op when the eye is quiet. Okay, so from Dr. Tay Wee Min, a question for Dr. Sangeeta. Is checking the patient's blood sugars necessary during injection day? Is there a cut-off point for blood sugar reading to defer injection on that day? That's very important. Most of our patients, diabetic patients, are not very well controlled sugars. So Dr. Sangeeta answered that there's no standard guideline on this, but we do advocate good perioperative blood sugar control. Injection day sugar should be below 10 millimole per liter.
Yeah, regarding that, due to high volume of patients, in some settings, we won't be able to test every single patient, but we always, before initiating injections, we always make sure we know the HbA1c and we know that this patient has got generally good control. And whenever needed, at a suspicion of there's any high sugar, we will always check and accept ranges below 10 for injection.
Okay, so the last question by Dr. Adeline. Hi, Amelia. Would the post-cataract op steroid tapering regime, as you mentioned, apply for GDD surgeries in a uveitic eye as well, or do they need a slower tapering regime? So Dr. Amelia has answered that the tapering regime is just as a guide for you to taper your steroids if the inflammation is in a controlled manner in any types of surgery or procedure. However, if the patient has severe inflammation in the post-op period, you may need to taper slower and you may need to add a second line to control the intraocular inflammation. Basically, you just have to observe clinically. Okay, that's all the questions that we have for today. Okay, I'd like to thank everyone for participating or for attending our webinar for today. Thank you to Dr. Amelia, Dr. Sangeeta for excellent talks. We've learned a lot today. Okay, so we'll see you all next time during the next session.